All right, good morning, good afternoon, good evening, wherever you are in the world and whatever time you're watching this interview. My name is Mick Hughes, founder of the ACL Hub, and I've got the pleasure today of talking shop and picking the brain of one of America's finest sports and orthopedic physical therapists, Laura Opstedal. Laura, welcome to the show. Welcome to the ACL Hub.
Thank you, Mick, for having me.
You're welcome. Well, I hope I pronounced your surname correctly.
Yes,
Ah, very
perfect.
good. Perfect. Excellent. Very good. Well, Laura, there probably wouldn't be too many. I've got I was t saying to you just off air that most of my audience that will watch this is, yeah, mostly physios, but a few patients. But I'm also noticing there's a lot of physios coming from the US. So there'd be probably a few people that know you, maybe have been taught by you, maybe have been treated by you. But for those of my listeners that are down here in Australia or in different parts of the world, do you want to just give us a little brief bio of who you are and what you do, and yeah, what you like to treat and see?
Sure. So I'm a physical therapist in Montana in the United States, and I've been in practice for 25 years, mostly in sports medicine. And really early in my career, I worked in a clinic that saw predominantly ACL injuries because we worked with a lot of soccer players. And that's kind of where I developed a strong interest in ACL rehab. And here I am 25 years later. I own a clinic that specializes in ACL reconstruction. Now we've been in business for 7 years. And so I would say it's probably 60 or 70% of our business. And I have four other PTs that work with me. And additionally, I started teaching about a year and a half ago. I do ACL rehab in a weekend course, so 2 day course in the States. And that's been super fun. I've had 6 weekends, I think, 5 or 6 weekends under my belt. And like everyone else, it's a learning process. I am still learning 25 years later. I'm still changing things. I'm still making mistakes. I'm still learning from my mistakes and uh, hopefully headed towards retirement. The next 5 years or so, we'll see.
That's it. We'll figure it all out in retirement when you got more time to think about and reflect. But it's a nice like it's a humbling experience being still learning, and I'm in your boat. Like every week I think, oh man, I should have done that better, or like I reflect on 2 years ago and think, 2 years ago I thought I had all my shit together. I had my ACL rehab protocols and algorithms and all the things that sort of turn the cogs in my brain. I thought I had it all figured out, but then there's always a few patients that humble you and make you realize you don't have everything quite figured out yet, or with the ACL landscape too. What was published 5 years ago, now is being challenged, or yeah. No, it's nice to be able to sort of acknowledge that and reflect as well that it's just an ever evolving learning process. So, oh, that's cool. It's
Yeah.
good. Yeah. Were there any particular kind of people that, early in your career, or even still now to this day, you learnt from, or were mentored, or yeah, just for any resources or people that, who are sort of starting out their ACL, journey and wanting to know more, learn more? Are there any particular people that have really helped you along the way that other people might want to have a look at or listen to?
I think with a lot of people, I would say Eric Mita.
Yeah.
He was key for me. I've known him for several years now, but I think like all of us, we've interacted on Twitter in the good old days pre
Yeah.
2020,
Yeah.
and just started thinking about things quite a bit differently because of him. And he and I ended up being good friends. And so he sort of encouraged me to get more into the continuing education piece with ACL rehab. And then I would say Rob Panarello is another one, really just applying strength and conditioning principles and being very intentional about how I'm programming
Yeah.
my sessions and outside of my sessions. So, yeah, those two have been most influential to me.
Yeah,
Probably.
excellent. Yeah, 100% agree. Eric, I had Eric on for an interview probably middle of last year, and yeah, he's been someone myself that I've learned a hell of a lot from a distance via social media and his blogs. But the occasional time I actually get to sit down and talk shop with him just like this, I always pick up a few new little things. So yeah, so if any of the listeners that have not caught Eric's conversations that I've had with him, they're freely available too. So make sure you go back and watch them on the ACL Hub. Um, yeah, and so probably let's sort of dive in a little bit more to that learning stuff. Like one of the hardest things I've sort of started to manage lately, or I've started to really scratch my brain about from time to time, are quad tendon grafts. Uh, I've heard you sort of comment about them as well from time to time. What's your experience there with quad tendons and the challenges you face compared to maybe some of the other harvest sites? Yeah, I still don't know how to figure them out. Some of them they're just hit and miss for me. Like some of them run smoothly, some of them are a really bumpy ride and less predictable than hamstrings and patella tendons. Have you had similar challenges and how have you overcome them?
Yeah, definitely. I think when they go bad, they go really bad.
Yeah.
Uh, and it comes down to aggravation of the quad tendon donor area. Once that gets ticked off early on, it can be problematic through the entire rehab, and it's just hard to get people back on track. Additionally, I think if you're not loading that area very well or intentionally in the beginning, you could get further in rehab where you're starting to pick things up a bit and it kind of rears its ugly head again. So it's typically like the painful donor area with those guys. And what I have found is to um, take it easy in the first 12 weeks. I mean, we used to be
Mm.
super aggressive with our ACLs and push them really hard in the beginning and things would turn out well. If that happens with the quad tendon ACLs, it just can go sideways. And
Yeah.
so, yeah, we're just a little bit more careful with how and when we're doing isometrics or short arc quads or long arc quads in that first 12 weeks.
Yeah.
Once that 12-week mark, we can push them quite a bit harder. So I feel
Yeah.
like we're sort of like tiptoeing around that area in the first 12 weeks. And
Yeah.
if we can get to that point and it's not aggravated, then we're good to go the rest of the rehab.
Yeah. So it sounds like we just hold on for dear life for the first 12 weeks and do what we can without annoying it, and then we can go a bit harder. Do you find any I don't know, I found lately because I had a couple on my list and touch wood so far so good where we're probably in that first 12-week mark. In that 12-week period, we've been able to hold on reasonably well with their quad strength. I've found just adding even like that early specific and targeted rec fem work where we just got that little lean back on an ACL machine and no weight, just simply just getting used to that kind of rec fem specific targeted tissue. I don't know. At the moment, it seems to be doing a pretty good job, and the proof is yet to come. Like in the next month or two, when we start going a bit heavier and we try to push things. But certainly the first 8 weeks so far, these two recent guys I've been working with have been pretty smooth, touch wood. But this is where, like in the past, it's just been like I've had a couple of smooth guys and I've had a really couple of bumpy guys. Have you noticed? Is there something? Because with the quad tendon, they sometimes take a bit of bone. Sometimes they'll have purely soft tissues. Have you seen anything from the surgical procedure that may influence the bumpy ride, or is it still just one of
No, I mean
those?
we see both all soft tissue and bone plug, and
Yeah.
they they're about. I wouldn't say one is better than the other. There is some thought with full thickness graft harvest versus partial. Most surgeons are doing partial,
Yeah.
so I wouldn't say. And I can't make a comment about that just because I haven't seen any full thickness graft harvest. Um, Our surgeons are starting to add LET to with most of their pivoting athletes. I
Yeah,
don't think that changes a ton. I think it's literally, as you said, just extending the hip so you have a little more passive tension on the rectus femoris as you're
yeah,
loading up. So we'll usually start with short arc quad actually first because the
yeah,
moment arm between the quad tendon and the knee joint is the smallest between 0 and 30. So
yeah,
if you want minimal load to the quad tendon because it's, freshly, tissue ripped out of it
yeah,
fairly recently, we can start there and then moving into deeper levels of flexion with the hip extended is
yeah,
kind of what we do. We'll use a lot of BFR in the beginning just because any additional load will aggravate. So it could be like the weight of the leg and BFR and, bring them to a good amount of fatigue. And then also isometrics with the hip extended, knee at 90 degrees.
yeah,
We'll do two tolerance. So we just don't allow any pain more than a 1 or 2 out of 10 in that first
yeah,
12 weeks. So there's always a way to regress things, or maybe you add BFR so you can add a stimulus to the muscles without aggravating it. And then once you get into the 12-week mark, and you can hammer it pretty well, but there needs to
yeah,
be like a ramp up. It needs to be kind of a progressive load in those 12 weeks.
yeah. Yeah, I like that, and I think that's some good messages there, especially with the pain tolerance. I think we sometimes in the early stages, both physios who are sort of starting out in their career, or even patients, they're kind of like they kind of it's all or nothing. It's like they avoid pain altogether, or they probably don't know which pain to listen out for because maybe in the past they've been told, oh, you could just push through the pain. It's only anterior knee pain. It's only Harvard site pain. Like you can push through it, just grit your teeth and get through. It's like no, like there's there's that small little threshold that you actually will cause a positive adaptation. And sometimes if you have always zero pain, then we're probably not pushing hard enough to create a real positive adaptation. But then obviously if you're pushing into too much pain, we're just going to keep you on this really crappy pain roundabout that just goes round and round and round, and you can't get off. That's cool. Do you think because I'm probably a bit judicious in my BFR approach. I probably sit more on the rarer use side of things, and I just try to sort of get some isometrics in early if they can handle it. Then we do some, kind of just gentler load and sets and reps and see if we can sort of just get through without it. There's been always a few people that say that sort of get me to a point where it's like, okay, enough's enough of this kind of trial period. Let's just get the BFR on. Do you think with quad tendons, it's almost like these guys probably need you probably need to be on the bit more of a proactive response side of things with just with that lack of tissue tolerance and the known flare-ups there. Like, would you sort of see BFR as a more must-have as opposed to let's try heaps of other things first? Like where do you kind of sit with that?
I think so. Yeah. I mean, I I wouldn't I wouldn't not use it with this population. We use it for all of our ACLs just, to get some hypertrophy in that first 3 months. We don't typically use it after 12 weeks. It's
Mm,
just like as soon as they're able to push harder or you're able to add more resistance. Once they can tolerate resistance, it's definitely not a replacement for good loading. It's just with the quad tendons, they could be so tender in that donor area. The BFR works great where we can bring them to muscle fatigue or muscle failure, quad failure early on without pissing anything off.
yep, yep. And for those that haven't really dabbled in BFR, um, is there an early, like a minimum time frame? Would you give like the first week, or are you starting from day one with your blood flow restriction? Are you sort of waiting at least a couple of weeks? What's your kind of usual processes with adding BFR with your ACL patients?
We'll usually start after the first week. So that like initial angry surgery pain where we're just kind of working on extension and getting them to volitionally contract their quad. Once we think that they are ready to handle the discomfort of the BFR,
Yeah,
typically after the first 7 or 10 days, then we then we do it. I have home units that I bought 3 extra H plus cuffs that we loan out to our patients so they can do it at home too.
Yeah, nice. So that gives them that because it gives them that kind of extra like because classically all your research papers in really clean clinical trials are always pretty much like twice a week, 3 times a week maximum. Are you going beyond that, like with your sort of planning? Are you asking the patient to sort of, do their home exercises with them with it on as well, or are you sort of trying to sort of keep their dose to I guess a
We
research?
try, yeah, we try to get 3 to 5 sessions in a
Yeah,
week. And it's just, like for quad tendons, it would be like a supine leg extension. So hip extended, longer quad,
yeah,
um, the oxidative protocol, which is 30 reps and then 3 sets of 15.
yeah,
We'll dose them with a Doppler in the clinic. So we've got 80% limb occlusion pressure.
yeah,
And it doesn't change like a ton, but we'll recheck it every couple weeks and just make sure the dosage is right.
yeah,
And then away they go.
yeah. No, that's very cool. And similar approach with hamstring grafts, patella tendons, allografts. The protocols don't necessarily shift so much.
Yeah,
Yeah,
it's just positioning. So the
yeah.
quad tendon is always going to be hip extended. Everyone else can do it seated.
Yeah, yeah, cool. And your messages too then say hamstrings also too and patella tendons around the pain experience. Would that be the same too for those other harvest sites?
Uh, yeah, I'll let him go a little bit higher. I've backed off a little bit on the patellar tendons too
Yeah,
because we've just had a couple of them get aggravated. So we're still like 1 to 2 out of 10. I don't typically have any issues with our allografts or our hamstrings.
yep,
So yeah, they'll get a little sore in their hamstrings, but I mean, the semitendinosis was removed, so you're
yeah,
not really protecting anything per
yes,
se.
yeah,
So
yeah, agree. There's we've historically here in Australia, I think most of the surgeons I would comfortably say would do hamstring autografts as their primary tissue. I've been lucky enough to work with a surgeon who did a lot of US-based training early on in his career here locally in Townsville, and his primary is a patella tendon. And in the last 5 years, I don't think I've seen as many patella tendons as what I've previously seen in the first 10 years of my career. So it's so nice working with them. The ones that I was seeing in Melbourne when I was there for a big chunk of time, they were all revisions. And we know with revisions, things are just naturally a bit slower, and they've been on the roundabout. The knee joint's never as happy, and the things are just never as clean and tidy inside the knee. But these primary patella tendon, I'm just really enjoying working with them. Yeah, I think I used to be scared of that anterior knee pain. I'm not seeing a lot of it, and I think that's where probably what you see in a textbook, and it's probably a bit more of a message for the young clinicians not working with them yet. I think what you see and hear in the textbook with anterior knee pain is almost like it's a given. It's like as if, yeah, if this is what tissue is being removed, yeah, you're just going to have to just get on with life and just deal with it. But I haven't yet experienced a uniform response where this person at 6 months, 12 months, 18 months is still dealing with really aggravated and irritable anterior
no.
knee pain and they can't kneel on their knee. They can kneel on their knee and they're actually quite comfortable doing so. Yeah, like what's your kind of sort of experience and maybe some messages there about the patella tendons that have got this sort of bit of a bad rap of having ongoing and persistent anterior knee pain for a long time?
Yeah, I mean we haven't seen that. I think I'm not really sure. We still have surgeons tell people that,
Yeah.
like I don't want to tell their tendon graft because you lay carpet for a living, for instance, and you kneel on the knee or you wrestle or something like that.
Mm.
You just don't see a lot of that. Every once in a while, we'll get just patellar tendinopathy. We just overcooked them at some point, and the tendon got a little sensitive. But uh, as a, I guess, heuristic, I don't necessarily see a bunch of anterior knee pain with
Mm.
them. We'll have them do kind of a graded exposure with kneeling just to mitigate that. So like just start putting pressure on it in like quadruped or something like that.
Yeah.
And but no, I think I don't see a whole lot of that.
Yeah, yeah. It's like I've literally had patients say, "Oh, should I have a patella tendon or a hamstring because I'm really worried about kneeling. Like it's part of my life, part of my job." And the surgeon said, "I'm just going to have anterior knee pain and kneeling pain for the rest of my life." And I'm like, "Man, that's it's not true." Like,
I
anyway,
think
it's
it's historically with them, it's just, I mean, I'm assuming you're as old as I am, but back in the day, we weren't allowed to do knee extensions ever,
yeah,
like a contraindication after the surgery. And so I think they got anterior knee pain because they were not doing
yes,
knee extensions and they didn't have good, torque output in the quads.
yep,
And then
yep.
they were asked to go ahead and start running now, and they just weren't ready. So yeah, they ended up with
Yep.
anterior knee pain.
Anterior knee pain. Exactly right. Well, we'll stay there for a second on open chain and knee extensions. What's your kind of approach? Of always, or every person that I've come on sounds like you're very pro. You've been listening and talking to Eric. You've been in the game for a long time. I assume and obviously hearing your early comments about quad tendons, it sounds like you're very pro knee extensions and open chain work. Would that be true?
Yeah, yeah, totally. um, we start doing uh, so the first 4 weeks, as soon as they have range, we'll do longer quads with minimal range because we've got the BFR, or
Yep.
sorry, with minimal resistance because we have the BFR. So could be just weight of the limb. It just could be like a couple pounds. So full arc, no resistance, with NMES and BFR. Um, we'll work into 90-degree isometrics, do a lot of those, with NMES also. And then
Yeah.
at 4 weeks, we'll start doing partial range knee extensions for our quad tendons and our patellar tendons. Or
Yep.
sorry, at 4 weeks, we'll do full arc knee extensions with our quad tendons and our patellar tendons. And
Yep.
then partial range 90 to 50 for our hamstrings and our
Yeah.
allografts, just because there's a little bit of creep with the hamstring grafts, and
Yep.
there's not really a difference between doing partial and full anyway. So I'd rather be safe than sorry.
Yes.
And then at 12 weeks, we'll do full arc with
Yep.
the hamstrings and allografts.
Yep. And just go for it and progressively overload. It's
Yep.
that's very much in line with what I do, which is always nice and comforting and reassuring when I talk to fellow experts to hear that my practice is very much in line with what other people are doing around the world, which is cool. How do you yeah, I guess early on in your career, even now, like how do you broach the topic with surgeons who are still, no open chain or yeah, are there any, I guess tips that you can give to, any clinician who is meeting with a surgeon or is having their patient turn up with a protocol that says no open chain ever or no open chain for 6 months or whatever the comments are, which are obviously outdated and needs a good refresher in the safety of the open chain. Have you got any tips on how we can sort of go about that conversation with the surgeon?
Yeah, I mean, to have just meet with them and have a conversation and ask what the concerns are. Because I think I was a little surprised with one of them, just didn't want his quad tendon donor sites aggravated. And
Yep,
so the solution for him was just to say not to do them at all,
yep,
you know, and ultimately it's, I mean, it's a tough topic, right? Because ultimately they're the surgeon and we have to kind of follow their wishes. And there's lots of ways to try to constrain a closed chain exercise, for instance, and really load the quad. And sometimes you just have to be prepared to do that.
yep,
It doesn't happen that often. Everyone else, I think, if they're worried about graft laxity, there's lots of studies that you can throw at them. I have a list in my course
yep,
um, of references that you can just give them. There's no evidence for graft laxity, so don't worry about that. And every other conversation I've had has been really positive. Like, oh, okay, well, I trust your judgment,
yep,
and it's kind of course you should trust our judgment. That's like
yep,
this is our lane, that's your lane.
yep,
But I think it helps having a relationship with the surgeon and a degree of trust. And then they're like, okay, well, I see good outcomes from you, so
Yes.
you do
Yep.
what you're doing.
Yeah.
Um,
And I think
hopefully,
that's
nobody breaks a kneecap when they're doing a knee extension, or
yeah,
you know,
yeah, that's always yeah, it's always that kind of it's a very low grade risk, but it's going to be one of those things that with the conversation, I think it's really important. Like when sort of similar kind of messages from other people I've asked the same question is that the consistent theme is coming through that it's having a actually real life conversation as much as possible and having a relationship with the surgeon. I think there's very little to gain by, blasting their inbox when you haven't met the person or, maybe potentially even jumping on a phone call and not physically have met the person or have not visited them and watched them do surgery or had an opportunity to actually have a chat. I think if you just firing off, emails or just blasting their inbox full of research articles that refute their opinion and advice, and they don't know you from a bar of soap. I think that's where you'll run into problems and meet a lot of resistance. I think that important step to maybe meet them in the OR and watch them do surgery, have a conversation because they're busy, we're busy, but I think if you really feel strongly about this to improve your patient outcomes, there has to be some steps made by you to engage with the surgeon and have that conversation and that's what I always sort of that message at the end is that if we are providing our patients back to the surgeon for their reviews in really good shape, with low pain, with good strength levels, and good tissue tolerance, the surgeon is going to love that. They just, I can imagine how difficult their days be when they see 30, 40 patients in a clinic and they're all coming back with pain and complaints. And you got a few patients who come back happy and are thrilled that their knee is feeling so good. That surgeon's going to start remembering your name when it's attached to the patient. So Um, yeah,
exactly.
so yeah, that's cool. Um, what I've seen you also too manage quite a lot of Achilles ruptures. How are they in your rehab approach? We'll probably dive a little bit deeper into ACLs in a second, but I was just thinking that, yeah, is that a big chunk of your list? And if so, like are the strategies that you apply to ACLs, I guess the framework pretty similar for Achilles, or is there just some obviously big differences there along the way?
Yeah, I think I've applied a lot of principles from my ACLs to the Achilles. It's just
Mm,
like a different area, obviously. So um, we I used to see a lot of them when I worked at a surgeon's practice. When I worked in a physician-owned practice, I usually had like 8 or 9 Achilles repair patients going on at a time, so pretty high volume. And since I've opened my practice, we see a few, not like as much as I used to, but with those we are really intentional about how we load the repair early on,
yeah,
just like how we would load a ACL reconstructed patient, um, and just be intentional there with progressive loading. And that looks like, as we're doing early isometrics into plantar flexion, we would have them mid-range or at least in a little plantar flexion, so there's minimal strain to the repair, and then have them push into a force plate so we can gauge the amount
yep,
of output that they're producing and make sure that that is within the parameters that we give them for said stage of their recovery. And then
yep,
also we'll do BFR early on with them too,
yep,
for separate reasons, just trying to maintain calf circumference. So they
yep,
might do some like plantar flexion with the BFR multiple times a day, or with cycling on the bike, for instance. And they're, I mean, I would say our Achilles repairs do really well.
yep. Is the BFR unit attached up high in the groin
Yeah.
for calf still? Like
Yeah.
you don't bring it down any lower? Yep.
Correct. Yeah. You don't want to put it below the knee because you'll give them a
DVT.
peroneal
Yep.
nerve palsy, probably. Um, yeah. So it's up in the groin too.
Yeah.
Uh, And there's I really enjoy working with um, Achilles repairs. I think
Yeah.
they have different challenges you're trying to avoid, like avoidance of lengthening the tendon,
Yep.
stretching, and the I don't we don't really stretch them at all. I think once they're walking normally, it kind of naturally stretches out to where it should be.
Yep.
And I think literature says the Achilles tendon will lengthen up to 12 months. So we're
Yes.
really
Yeah.
trying to keep that tight. And then end range plantar flexion strength, which probably isn't a huge performance deficit, but we do try to address it with different things in the clinic.
Yeah. Yeah. I think like obviously we got different. I think the time frames, from a young clinician who might see the occasional Achilles, repairs like the ACLs and Achilles and patella tendon repairs, and they're all that sort of similar time frame of that kind of 12-month period for return back to play if that's their goal. Rough roundabout for our non-professionals, but it's probably even like that same approach. You want to protect that first 12 weeks as much as possible, and we're dealing obviously different with excision of a part of the patella tendon as opposed to the stitching back of it. So, but the tendon effectively has been abused in some way and remodeled and has to remodel over a period of time. So that first 12 weeks is probably that same kind of the barriers and the limitations are going to be there. And then from 12 weeks onwards, we're taking a similar graded stepwise approach back to their running, jumping, sport, and that kind of stuff. So the frameworks are it seems very similar. Obviously, just looking at a different tissue. It's my greatest fear actually tearing my Achilles. So it's if I know who to come to if I run into any trouble, Laura.
We are that.
Do you see many non-op ACLs in your practice or conservative treatment?
Yeah, once in a blue moon.
Mm,
They're typically there's definitely like a profile with them in our area. We've had a few recently, and they come in and they're in their early 40s or 40s typically, and they didn't realize they tore their ACL, or maybe they did, but they never had any instability. And so, like, if we get them in the office before they have surgery, and they're like, it's never unstable, it's
mm,
not buckling on me, and they don't have a hard timeline,
yep,
then I always offer, like, why don't we just see if you will do well without surgery? And
yep,
depending on the person, they're all for it. And we've had even like a couple skiers go the non-op route. I know Lindsey
yep,
Vonn is
yes,
recently toured hers, and I'm super excited to see how she does in the
yeah,
Olympics. Um, but the every once in a while they do well. We've only had one that she ended up tearing her meniscus pretty bad.
yep,
Um, and
yep,
that was the one that kind of spooked me a little bit. Like, oh, I really thought that she could manage well, but that's part of the conversation. Like, like you are at risk to possibly tear meniscus or cartilage
yep,
without your ACL. And if you can accept that risk, then we're willing to see how things go. And
yep.
the rehab looks similar. We do a
Yeah,
serial
absolutely.
and all the jumping and things like that. But I would think in Australia is probably more common.
Yeah, it is. The it surgery still is the number one treatment option for most. It still hovers, I think, roughly about 90% of cases will get reconstruction. There's definitely a lot more openness, or maybe also got that clinical bias and where I'm happy to sort of because I have hour-long sessions with my initials, so I've got the time to have like that really broad conversation about okay, well, this is your non-operative path. These are the options here. We could, if you're a suitable candidate, cross bracing here is being sort of developed by one of the sports physicians in Sydney, and here's his protocol. But we just need to make sure you're a suitable candidate first. That's an option. We've got just the straight non-braced option. This is how it look like, and of course, here's your ACL sort of reconstruction. So it can sort of have that time to have that really deep conversation about risks and benefits, pros and cons, and all that kind of stuff. There's definitely with our younger, I think there's still at default with a younger population to elect for surgery. It definitely carries a lot more, I guess, predictable pathways. It's still never perfect and it's still often very bumpy, but at least with confidence based on the research that exists, that we know that, this is the expected timeline and this is the process that we'll take and these are the outcomes that we know. Whereas non-operative, I sort of, it's still a very grey landscape, and this is not just in Australia, but everywhere. Like it's this kind of 50-50 gamble. Like you could have a great result, and you could go back to sport and you could be this unicorn that goes back to sport, goes back to do the things that you love to do, never to see an instability episode ever happen again. Meanwhile, you could be this other 50% who kind of gets 3 months in, starts running, jumping, and has an instability episode and worsens their knee. So but there's really nothing today that I can sort of test you on to give you an idea of will you be over here in the re-injury column or will you be over here in the unicorn column? So it's yeah, it definitely. It seems like we're probably a little bit more open to having that conversation, and even some of the surgeons, younger surgeons, I'm sort of dealing with occasionally. They're happy to trial non-operative periods with their patients as well, rather than having it be the default. So I manage quite a few, but yeah, those ones that do re-injure, same thing has happened to me a couple of times in the past where they've had big meniscus tears on a knee that's ACL deficient, and they've had to go have meniscus repairs, and yeah, it rattles you when you are part of that process. But lucky enough, in both cases, they were able to successfully stitch the meniscus back together, which was probably a better outcome than having it completely removed.
Right.
So yeah. But yeah, it's there. There's still obviously a lot to know, lot to learn. Cross bracing protocols definitely interesting here in Australia and New Zealand. It seems to be the uptake of people trying it is growing, and there's a randomized control trial currently underway here in Australia where they've got a couple of centres who are comparing a 12-week bracing protocol to a standard ACL reconstruction, and that data should be out in the next few years once they've finished the trial. So I think that'll be the big that might be a little bit of a turning point in how we manage ACLs in the future, depending on the results there. Uh,
Yeah, we haven't seen any cross bracing in the States. At least I haven't.
yeah,
I'd be
yeah,
really to see how that turns out.
yeah. It's a very if you haven't seen any of the kind of parameters around it, it's a very select patient that effectively can be recommended the bracing protocol now. Like it used to be the first paper that came out a couple of years ago where they had the first 80 participants and they tracked their changes over 12 months. It was kind of like, welcome to this kind of study, and let's sort of see what sort of holds up at the end. And after discovering, those that healed were more likely to have mid-substance tears versus femoral attachment avulsions. That was like a big inclusion now. So anything moving forward, like Dr. Cross will say, if it's mid-substance, we can go ahead, but the gap distance between the two stumps also needs to be under 6 mil, or thereabouts. Difference. If it involves the femoral attachment, then probably got slim chances of anything recovering here. And then the time you need to have it braced within ideally in the first 7 to 10 days, if not straight away, for a good bridge to bring the two tissues. So you kind of have to have a few things in your favor to be ready to go in that process. But also too, if it's your right ACL, like here in Australia as well, if it's your right ACL, you need your right leg to accelerate and brake in a car. So it needs to be the right limb as well. So there's a few extenuating circumstances that might align you to following the cross bracing protocol, and if you're one of these lucky few people who can undertake the process and turn up 12 weeks later and your ACLs really united nicely, still got another 6 to 12 months of revascularization and healing and growth and developing some more stiffness there in the ACL and hardening up. But at 12 weeks, some of those early signs are pretty promising for a select few. So yeah, time will tell. Like everything, the ACL landscape's pretty cool. There's lots of new things happening, and there's each year, every couple of years, there's some nice new research that makes us rethink our practice.
Mm-hmm. Yep.
Yeah, yeah, cool. Just moving into the patient perspective for a second, how do you kind of, I guess, navigate those patients that are maybe going a bit slower? And they're, for some athletes who are frustrated by slow progress, and the clinicians who are feeling pressure to push them, how do you sort of, I guess, frame those early days where you are doing less, um, and even potentially later on where, you are, pushing them, but you're also too not thrashing them every day, I guess, how do you sort of deal with those frustrations, to the patient?
Yeah, early on, I just try to break up, not give them a bunch of, so I give them a bunch of information prehab, kind of like lay out what this entire rehab is going to look like. And then they come in for post op, and I try to keep things very simple. So, first week, it's like your focus is going to be on knee extension. And that's,
Yep.
like something you're going to work on every day in a very attainable goal in a short period of time. I think that works best on breaking things up like that instead of being like, you got to do this, that, and these other five things. It's just primary goal first week is knee extension, get your swelling down. And it kind of feels like I always make the joke because I have these spreadsheets I give them on what order and what they're doing early on. And it's like, you're not doing a lot, but you're doing a lot.
Yep.
Like their definitions of doing a lot is being in the gym and doing, 6 or 7 different machines or whatnot. Um, but doing a lot is like working on your knee extension, taking your knee through as much flexion as you can a few times a day,
Yep.
stimulating your quad with the NMES. It eats up a lot of time.
Yes. Yep.
So, so I think breaking the goals up like that is super helpful.
Yep. Yeah, agree. It's a less is more approach, but it's still a lot for the knee. And it's a lot for the knee that's just recently had surgery and has had, an injury followed by surgery, and has had a lot of trauma. And it's multiple sessions a day too. So yes, the person might be doing a lot, in their normal everyday life outside of an ACL injury, but they're not training 3 times a week or 5 times, sorry, 3 times a day or 5 times a day. Like this is, these early weeks where they might only have a handful of things to do or less than a handful of things to do, but they've got to do it pretty relentlessly. So that's a really important message to get across. I'm a big fan of just, 1 or 2 things done, pretty
Mhm.
relentlessly well. Especially in that first month where pain and swelling's a real bastard. You really want to get after that.
Yeah, yeah.
Yeah. Cool. Well, fast forwarding then, and I'm probably just conscious of time here as well, but what are some of your like non-negotiable return to sport tests? If we know like tests aren't perfect, we still got to get them on the court and get them to pass sport specific, drills and get them confidence and that kind of stuff. But if there are any sort of, key clearance tests that you'd want them to hit first before we really open up unrestricted training and the thoughts of sport again, what would those kind of, top three or top five be for you?
So our testing battery that we do every month, and this would change, the further out they're out from rehab. So I'll just say like end stage battery would be isokinetic testing. So at 60 degrees per second, we're doing concentric quads, eccentric hamstrings. We'll start, or sorry, concentric quads, concentric hamstrings. And then once that symmetry is 80% with concentric, we'll add an eccentric.
Yeah.
Additionally, we'll do a quad rate of torque development test isometrically at 60 degrees. And then on force plates, we'll do a counter movement jump and a single leg vertical jump, and then a drop jump.
Awesome. To
And that's
the two-legged drop jump or one, or are you doing a mix of both counter
we'll
movement
yeah,
and
both
single?
depending where you're at. Yeah. So
Yeah.
if their double M drop jump is looking, uh, they've got the same counter movement jump height on their drop jump, and
Yep.
they're doing it at a ground contact time of less than 250 seconds. We
Yep.
pass that and we start doing single leg, which will be from a shorter height, most likely.
Yep.
And then we'll do 505 testing, and we just do qualitative 505 testing. I don't time it anymore. We used
Yeah.
to
Okay.
do,
Yep.
yeah, the timing gates, and it wasn't really giving us as much like useful information.
Yep.
Um, and so we'll just do like a slow motion video and just make sure they have their body positioned with good braking mechanics.
Yep.
Um, and and then yeah, that's the testing. But there's so much other things too that I would include in testing. It's like, what are they allowed to do at practice? Is it going well? Are they getting
Yep.
knee effusion with it? What's
Yep.
their report from their athletic trainer? All of
Yes.
those things. Are we hitting all the plyometrics that we need to do in the clinic? Have
Yep.
we addressed side step cutting? What does their deceleration look like?
Yes.
It's like those things you aren't necessarily testing, but you're monitoring them, um,
Yep.
and getting some feedback from the patient or getting some feedback of what you see in the clinic. So that stuff is just as important to me.
Oh,
And then
100%.
at the same volume of activity that you are expected to be at when you return.
Yeah. Yeah, that's a huge point there, the last couple of things you said. Like, so I was consulting with a basketball player recently, and they were saying that, and all the numbers look pretty good. Like they were 9 months post-op. They're like the, the player and the physio were kind of there and together, and the physio was like, yeah, these are her, these are the quad numbers, these are the hamstring numbers, these are the jump performances. I was like, yeah, all this sounds good on paper. But she was having some really annoying, fat pad pain, and they were pretty confident it was fat pad. They'd had new imaging and re-imaging, and there was nothing really internally wrong with the knee, and they couldn't really find anything other than, really cranky little fat pad, and the pain was pretty consistent. And I was like, okay, well, that's kind of seems like it is what it is. And then I was like, what's the everyday like? Like, yeah, it sounds like you get some soreness at training. It doesn't seem to affect you in the gym. There's some things there. So what about, like, just basic stuff like, how does it feel when you go up and downstairs? And she goes, yeah, downstairs sucks. And I was like, well, okay, there's something there, like, because they were scratching their heads as to, what's the limiting factor? Because the quads look good in many different domains. It's like, well, if you can't handle a step down and stepping down in life and down a ramp or something like that, there's still something screaming out there in your quads being poor in its braking ability or its eccentric loading. Like, there's something there you just need to keep on attacking for a while, because the fat pad's obviously getting pissed off because it just doesn't have enough support up the chain. Or there might just be that tendon just needs a bit more, the patella tendon harvest side just maybe just needs a bit more remodeling and a bit more toughening up, and so that fat pad doesn't have to get pissed off. So yeah, that was I think that conversation outside of, those really pure, clean clinical tests where you can, pass the test, so to speak. It's the proof's in the pudding about, how is it pulling up that swelling, the swelling signs, the stiffness signs, the soreness, how it plays out in everyday life. They are super important questions you need to be asking, because there's a lot of clues there that will tell us that they've got a little bit of work to do if they're feeling it in other areas in everyday life.
Yes.
Yeah. Yeah, cool. Are there any certain safety? You said 80% for some changes in your testing, but I guess from a return to sport perspective, are there certain benchmarks you set then for those tests? For quad, 3 Newton meters for males, 2.5 for females. Like, what does that kind of, those goals look like for you as well?
Yeah, so with the isokinetic testing, we, obviously want 90% symmetry, and then we want at least 90% torque to body weight
Yeah,
with quads. Rate of torque development, we try to get over 13. Like, we establish our norms in our clinic as 13 Newton meters per kilo per second.
yeah,
And so when we test it, we want symmetry and then hopefully over 13. And there's no established norms for RTD. It's
mm,
just we pulled all of our non-affected leg data, and it on average was around 13. So we just decided that
yeah,
must be, you
pretty
know,
good.
that's our Bozeman, Montana
Yep.
normative data. So there's that. Our counter movement jump metrics need to look normal. So we break that up in phases. So eccentric or braking phase, depending on the force plates you have, because they're named differently. And
Yep.
then concentric or propulsive phase, we look at impulse, um, symmetry, and then some of the output metrics like power and RSI mod. Those
Yep.
are kind of secondary, but the symmetry on the impulse is more important to us. Um, Nice looking force time curves
Yep.
where we don't really pull the rate of force development data from it because it's a little less reliable. It has a
Yep.
higher of variation, but we can pick out what a good force time curve should look like. And then our single leg vertical jump would be our 90% symmetry with peak eccentric deceleration velocity, and
Yep.
then also counter movement depth, because I want to know if they're able to drop into a lot of knee flexion quickly
Yes.
and load
Yep.
the knee like that, equally side to side. The jump height will stay asymmetric for a while in my experience.
Yep.
We'd like to get normal, but it just does. And I don't think um, I think that persists for a longer period of time than we would allow for a return to sport. So it's depth and velocity for me on those two. And then drop jump. That wouldn't be necessarily a deal breaker if they didn't
Yep.
achieve metric on the drop jump, just because I just don't think it's a good test for the majority of our patients. But
Yep.
I do like to look at it in terms of what does this person's reactive strength look like.
Yeah.
Um,
Yeah. Love
yeah,
that. I think that's where often, young clinicians, and I was guilty of it many times over, is that you just go chasing that 90% target. And it's like, okay, yeah, the tick the box, great. Okay, let's go back to sport soon. But it's that devil in the detail. I think that's really, really key, is that you hit those kind of symmetrical markers to make sure they're moving evenly and sharing that load relatively evenly, but it's their performance metrics there that are going to probably set the side of and set the difference between those that are confident to move how they used to move and those that are potentially still a bit flat and a bit, yeah, need a bit of extra work to help with their confidence and their movement and performance back to sport. Cool. All right, two more last questions, Laura. If you've obviously, I've seen some of your clinics. Your clinic looks fantastic. You got all the tech. You've spoken about the tech, but what happens to a person that doesn't have any tech? Are there any things on a $0 budget? Like what would be something simple that a clinician could use in an ACL patient that would give them a whole lot of information? Is there any simple thing there that you've used in the past that works nicely for you?
I say this in my courses a lot. This isn't $0; it's $220. But
Pretty
heck,
good.
my gosh, like there's no excuses anymore. Let's be honest.
Yeah.
Like anybody, you can just not drink Starbucks for a month and be able to buy a tin deck. You have
Yeah.
to have something to give you some degree of certainty and in torque output,
Yeah.
over time. I think it's just so cheap. And now you can test rate, if your methodology is solid. It's just, I think you can get a long way with that tiny little device. You can train on it. I sound like
Yeah.
I'm for 10 deck right now,
Yeah.
but it's just, it's an incredible cheap device. It's just when you get to the end when you still like they look good isometrically, then you can refer them out to someone else that does isokinetic
Yeah.
testing. But the majority of time, you can get a lot of information from a Tindeck.
Yeah. And a lot of information like from your quad testing. Like that's the thing. Like Tindex's going to measure your quad. Do you use it for hamstring too, or just only quad mostly?
Yeah, you can use. Well, I have an isokinetic machine, so I
Yeah.
get my hamstring data from it. But
Yeah.
if I did not, then yeah, I would test hamstrings too.
Yeah, and that quad, as listening to yourself and listening to Eric, is that the quad's responsible for a lot of things that potentially can go wrong. And if the person's getting pain, swelling, loss of function, underperforming on quad or lacking a lot of confidence and whatnot, like you go to the quad first and see if there's anything missing or anything asymmetrical or anything wrong there. And if there is, then go about trying to fix that and tidy that up. And then a lot of these things that are bothering the patient magically start clearing up. So to have a unit like that to be able to test reliably and train on it, as you said early too, like because that's not just a mid range, late stage tool that you use. You use it from day one, day two, week one, week two, and to start that voluntary muscle contraction process to and give that biofeedback too. That hey, I'm using my quad here. These are my kind of force lines. These are my Newton outputs. Like it's a really valuable motivating tool, which I use similar in the clinic as well. So no, it's a nice cheap tool to use.
Hmm.
Cool. Now, lastly, Laura, this has been great, and I'm sorry I have to wrap it up. I could literally talk here for hours with you, and I probably missed a dozen questions that I probably would have loved to ask, but I better start getting ready for school and getting my kids sorted out. But if you go back to your early career and talk to a new grad Laura, what would one piece of advice be to a younger self, or now a younger physio who's listening today? What would that piece of advice be?
I would say never let this profession be more important than your family.
Yeah,
So it's
nice.
easy to get very wrapped up in career aspirations, but you have to save some emotional space for the people waiting at home for you.
Yeah, love that. Love that. It's something that sits and resonates really well with me, especially in the last couple of years. My kids are now 11 and 8. I've always wanted to be around, and 2 years of COVID actually, kind of forced my hand a couple of years back to be that, present dad. So yeah, no, I 100% agree with that messaging. There's probably the first one that said that. Some people have gone back and said, just keep it simple, keep the basics right. But I love that family. It's important. Yeah, they're the ones that are going to, make you happy. And you bring that happiness and joy to the clinic to help your patients. So, it all starts at home.
Yep.
Yeah, love that. Well, Laura, that's been a wonderful chat. I'll probably will have to do a part two with you at some point down the line and maybe dive a bit deeper into some of these things. And I really want to make some efforts to get to the States and learn off, get in the clinics with yourself and Eric, and I've spoken to Lenny at Champion. I've spoken to Dan Lorenz, and there's all these, and Lynn Snyder. Obviously, there's all these wonderful US based clinicians I've spoken to, and I just need to make a priority to get to the US and steal a few of your ideas and tips and bring them down here to Australia. So watch out, 2027.
Likewise,
Yeah.
likewise. Australia's on my list.
Yeah,
So
come down, come down. Eric he's been teasing me with about bringing his course to Townsville, and Townsville's off the kind of usual beaten path, and he wants to run a course in Towns. We've got a great facility actually, which we'd love to run a weekend course here. So yeah, maybe have a look at that, and just outside of Sydney, Melbourne, Brisbane, Adelaide, the usual tracks. Yeah, we've got a great spot up here in Townsville for you too. It's much nicer than those other places. So
awesome.
plan it. All right, Laura, I'll let you go. I'll just log off now. Thanks very much, everyone, for listening and watching. As per always, ACL Hub, another interview in the books. Watch out for some more coming up over the next few weeks and months. And thanks always for your support for the ACL Hub. Until next time, we'll see you then.